So imagine walking into a mechanic shop, right? And the engine of your car is making this awful metallic clanking sound.
Oh, that is never a good sound.
No, it's the worst. So the mechanic pulls out two incredibly complex blueprints. Like one is for a complete engine rebuild, and the other is just a localized fix for a few internal belts.
Okay, I can picture that.
And they slide both of these across the counter, look you right in the eye, and ask, which one do you want to go with?
I mean, in that scenario, most of us would just freeze. You can't really choose between two mechanical repairs if you don't even know what an engine looks like,
Yeah,
or, where the belts are, or how they actually interact with the transmission.
exactly. Yet, as we're diving into our stack of sources today, it turns out this exact scenario happens every single day in a really vital area of medicine.
Yeah, specifically in women's health.
Right. We're talking about pelvic floor disorders. And to put this in perspective for you, there is a UK study in our stack by El Hamamzi and colleagues. This was from 2022.
Oh, that study is fascinating.
It really is.
Yeah.
They handed women at a hospital just a simple diagram of external female genitalia, and only 9% could correctly label all the key anatomical structures.
9%. That is just wow.
Yeah, 9%. And when they asked about symptoms, a massive portion incorrectly assumed that a pelvic organ prolapse just meant urinary incontinence.
Right, which it isn't.
Exactly. Only 35% knew that a vaginal bulge was the actual symptom of a prolapse.
That information gap is just staggering. I mean, if a patient is sitting in a clinic trying to evaluate the evidence for a really complex surgical repair, but they fundamentally believe a structural collapse of their pelvic organs is just like a bladder control issue, the entire foundation for informed consent is compromised.
Completely compromised. Which really brings us to the core mission of today's deep dive. We are taking a comprehensive stack of official clinical guidelines from NICE, that's the National Institute for Health and Care Excellence.
Always a heavy read.
Oh, definitely. Along with training curriculums from the Royal College of Obstetricians and Gynecologists, and some really cutting-edge literature on shared decision-making.
Right, to answer a very personal question.
Yes, we are going to use all these sources to answer a highly personal, incredibly difficult question for you. How do you actually compare the evidence between surgical and non-surgical treatments?
And I think it's important to say the stakes for answering that question are massive. I mean, by the time a woman reaches age 80, there's a 1 in 10 chance she will undergo surgery for urinary incontinence or pelvic organ prolapse.
1 in 10. That is a huge portion of the population.
It is. And these conditions cost the NHS something like £45 million a year to treat. So we are talking about an enormous population of patients being asked to make these highly technical, life-altering choices.
Well, let's just jump straight into the treatment options then. Because, looking at the sources, the evidence isn't just a simple binary of surgery versus no surgery.
Right, it's rarely that simple.
The sources outline this deeply established treatment ladder. And the baseline is pretty much always conservative, right?
Yes, exactly. First-line treatments are things like pelvic floor physiotherapy, basic lifestyle changes, maybe topical estrogen.
Okay, and then if that doesn't work, you move up to mechanical support, like vaginal pessaries.
Right, those are the silicone devices inserted to literally just prop up the prolapsed organs.
Right, so when a patient is weighing a pessary against, say, a native tissue repair, which is where a surgeon physically stitches the patient's own tissue to reinforce the vaginal walls, they are essentially weighing temporary adjustable mechanical support against a permanent anatomical alteration.
That's a great way to put it. And that comparison becomes, honestly, exponentially harder when you start introducing heavily marketed newer technologies into the mix.
The marketing, it's wild.
It really is. The medical evidence landscape out there is deeply fragmented.
I noticed this so much in the sources when we were looking at genitourinary syndrome of menopause or GSM.
Yes, GSM is a perfect example.
Because, when estrogen drops and the tissues become thin, dry, inflamed, it causes severe pain and urinary urgency. So people are understandably desperate for a fix.
They absolutely are.
And I was reading these reports in our stack from independent clinics pushing transvaginal laser therapy. So they use like erbium or CO2 lasers. And the marketing claims are phenomenal.
Oh, they sound like a miracle cure on paper.
Right. They report a 94% improvement in vaginal rejuvenation, massive patient satisfaction, just a total resolution of dryness.
Which is very compelling if you're suffering.
Exactly. If I'm a patient comparing, a messy topical estrogen cream to a quick laser treatment with a 94% success rate, the laser seems like an absolute no-brainer.
But there is a massive catch.
Yeah, because NICE and the International Urogynecological Association strictly classified these lasers as experimental.
So how does that work? Why is the official evidence completely contradicting the clinic data?
Okay, so this is crucial. It's because those clinics are relying almost entirely on short-term observational case series. Observational case series.
Yeah.
Explain what that actually means in this context.
Right, so it's a classic trap when evaluating medical evidence. An observational case series just means a clinic treats a cohort of paying patients with this expensive laser, asks them a few months later if their symptoms improved, and then just publishes the positive feedback.
Wait, really? So there's no control group at all?
None.
Isn't that just begging for a massive placebo effect then? I mean, if I pay thousands of pounds out of pocket for a cutting-edge laser, my brain is going to work very, very hard to convince me that I feel better.
Exactly. The psychological buy-in is huge when you spend that kind of money. And that is exactly why official bodies like NICES demand long-term randomized controlled trials, or RCTs.
Where they compare it to a fake treatment.
Right, a sham treatment. And they measure it over years, not just a couple of months. Because the mechanism of these lasers is supposed to be, controlled thermal damage.
It sounds a bit scary on its own.
Well, the idea is that the damage stimulates collagen production to remodel the tissue. But when you look at the longer-term adverse events documented in the NICE guidelines, the reality of that thermal damage actually becomes pretty terrifying.
You're talking about the scarring cases mentioned in the source.
Yes, the scarring. The guidelines detail cases of persistent and worsening dyspareunia, which is severely painful sex.
Wow.
There was one specific case of a 68-year-old woman who developed this crescent-shaped fibrous band of scar tissue right across the middle of her vagina following laser therapy.
That is awful.
Yeah, the thermal energy didn't just rejuvenate the tissue like the marketing claimed, it actually created a partial obstruction.
See, that drastically changes how you view that 94% satisfaction statistic.
Yeah.
It really highlights how you, as a patient, have to look at the methodology behind the evidence.
You really do?
Like, a glossy marketing brochure based on a 3-month survey is simply not the same as a 5-year peer-reviewed survey of the structural outcomes.
Definitely not. And, this tension between short-term innovation and long-term risk, it leads us directly into one of the darkest chapters in modern urogynecology.
Yes.
A chapter that fundamentally reshaped how patients have to evaluate surgical evidence today.
Right. We have to talk about the synthetic vaginal mesh controversy.
We do. It's unavoidable in this context.
Mesh was originally championed as this, brilliant, minimally invasive fix for prolapse and stress urinary incontinence.
That was the promise, yeah.
Instead of using a patient's own weakened tissue, surgeons would implant this plastic net-like fabric to act as a permanent hammock for the pelvic organs. And I imagine the early evidence probably looked fantastic.
Right, it did. The initial mechanical concept made perfect sense to a lot of surgeons. But the long-term biological reality was just a disaster.
Because the body rejects the plastic.
Well, it's a porous mesh, so the body's tissue naturally weaves through the holes as it tries to heal around it.
Okay. Kind of like pouring concrete over rebar. It
Yeah.
becomes completely structurally integrated.
That is the perfect analogy. Concrete over rebar. And that integration meant that when the mesh eroded, when the plastic literally started wearing through the vaginal wall, which happened in up to 1 in 10 women.
1 in 10. That's incredibly high.
It is. And when that happened, it couldn't just be plucked out. Patients suffered devastating chronic pain, severe bleeding, and nerve damage. Removing it became a highly complex, sometimes completely impossible surgical nightmare.
Our sources actually include the Cumberledge report from 2020, which reviewed this entire tragedy.
A very sobering read.
It is. And for me, the most chilling finding wasn't just that the mesh failed physically, but that the medical system failed the patients and how the evidence was presented in the first place.
That was the core of the betrayal, really.
Women were given heavily biased, inadequate, and frankly misleading information about the permanence of these implants and the true severity of the risks.
And the fallout from that mesh tragedy, it catalyzed a massive legal and cultural shift in how doctors and patients communicate risks.
The legal shift.
Yeah, it centers on this landmark 2015 UK legal case, detailed in our sources, Montgomery v. Lanarkshire Health Board.
This case blew my mind because it totally redefines what medical evidence actually is when you're sitting in a consultation room.
It changes everything.
Historically, we had this very paternalistic model of medicine, right? The doctor looks at the data, decides what they think is statistically dangerous, and only tells you the risks they deem important.
Doctor knows best. But Montgomery dismantled that entirely. It established that informed consent must be rooted in shared decision-making. And crucially, it completely redefined the concept of material risk.
Okay, let me just make sure I have this straight for everyone listening. Material risk is no longer just a complication that happens frequently, like, say, 20% chance of infection.
Right.
The law now says a risk is material if a reasonable person in your specific personal position would attach significance to it, regardless of how statistically rare it is.
Exactly. Let's consider like a professional musician who plays the piano. Say a surgical complication carries a 1% risk of permanent nerve damage in the hand. That might seem statistically negligible to a surgeon who just views a 99% success rate as excellent evidence.
Sure, 99% looks great on a chart.
But to that pianist, a 1% chance of losing their entire career is a massive, defining material risk. The medical evidence itself hasn't changed, but its weight shifts entirely based on the patient's values.
That is such a good example. And this brings us to a term that appears constantly in the shared decision-making literature in our stack. Preference-sensitive decisions.
A very important concept.
I want to apply this directly to comparing surgical options for stress urinary incontinence.
Let's do it.
So say a patient is leaking urine when they laugh or exercise, and all those conservative treatments we talked about have failed. The sources present two vastly different surgical routes. Option A is a colposuspension.
Which is quite a major procedure.
Right. They pull the tissues around the bladder neck up to ligaments behind the pubic bone. Now, the clinical evidence shows it works, but it carries a 17% chance of causing an overactive bladder.
Yeah, because the trade-off is mechanical. You stop the stress leakage by creating tension, but that new tension irritates the bladder, making you feel an urgent need to urinate constantly.
So that's option A. Then you have option B, which is a vaginal hysterectomy, literally removing the womb entirely to create space and reconstruct the support structure.
It's a totally different approach.
Completely. And the risks here are systemic. You have a 2 in 100 chance of excessive bleeding that requires a transfusion, plus a rare but documented risk of death, about 37 in 100,000 within 6 weeks.
Right.
So if I am the patient, how in the world do I weigh a 17% chance of bladder irritation against a rarer but catastrophic risk of a major hemorrhage? It feels like comparing apples and hand grenades.
It does. And the truth is, you cannot make that comparison using raw data alone, which is exactly why NICE developed patient decision aids, or PDAs.
It's PDAs.
These are clinical tools specifically engineered to help patients map objective medical evidence onto their own subjective life priorities.
Which is brilliant. I was actually looking at a study in the sources where patients used these decision aids to choose between a quick outpatient procedure called urethral bulking.
Where they inject a substance around the urethra to narrow it?
Right, exactly. They used the PDA to compare that to the major colposuspension surgery we just mentioned. And the decision aid proved that the best evidence is completely subjective.
How so?
Well, the patients who ultimately chose the urethral bulking looked at the evidence and heavily prioritized a fast, painless recovery. They openly accepted the statistical likelihood that the injections might wear off and need repeating.
They were okay with the trade-off.
Exactly.
Yeah.
While the patients who chose the colposuspension, they prioritized long-term anatomical permanence. They were willing to endure a painful recovery and accept that 17% risk of an overactive bladder just to avoid ever returning to the operating room.
Both of those choices were purely evidence-based. But the evidence was filtered through two totally different sets of human values.
The sources highlight another incredible example of this regarding uterine prolapse. It's this 5-year study comparing two distinct surgical approaches.
The hysterectomy versus hysteropexy study.
Yes. So one is the traditional vaginal hysterectomy removing the uterus. The other is a sacrospinous hysteropexy, which is a uterus-preserving surgery. They essentially use stitches to hitch the existing womb back up to a strong ligament in the pelvis.
Right, keeping the anatomy intact.
And the long-term data on structural failure here is fascinating.
It is, because the physics of the pelvic floor dictate those outcomes. The uterus actually acts somewhat like a keystone in an arch.
Oh, interesting. So keeping the uterus in the hysteropexy actually resulted in better structural integrity.
According to the study's 5-year data, yes. Patients who preserved the womb had a dramatically lower rate of repeat surgeries for apical prolapse, which is when the top of the vagina collapses. It was only a 1% failure rate compared to 8% for the hysterectomy group. Furthermore, they had far less posterior wall bulging, where the rectum pushes forward into the vagina.
Which sounds awful.
It's very uncomfortable. That risk was 5% for the preserved uterus versus 18% for the hysterectomy.
Okay, so on paper, The evidence basically screams that the uterus-preserving surgery is statistically superior for preventing those specific mechanical failures.
Hmm.
I mean, the numbers don't lie.
The numbers don't lie, no, but numbers lack context.
What do you mean?
Well, what if that patient has a strong family history of uterine cancer? Or what if they suffer from debilitating, painful fibroids?
Oh, I see.
Suddenly, retaining the uterus just to prevent a 5% risk of rectal bulging becomes a terrible trade-off. For that specific patient, the vaginal hysterectomy is the overwhelmingly superior choice, despite the higher recurrence rates for prolapse.
Wow, yeah. The clinical evidence just immediately flips polarity based on the patient's personal medical history.
Exactly.
Okay, let me challenge something here, though. We are talking a lot about the patient's bias and the patient's values, but patients rely on their surgeon to present this menu of options. Surely the surgeon is an objective conduit of this data. Like, they look at the NICE guidelines and just hand me the unbiased menu.
That is, without a doubt, one of the most dangerous assumptions a patient can make.
Really?
Oh, absolutely. The literature on shared decision-making is very clear on this. Surgeons are deeply influenced by their own biases. The evidence they present to you and the enthusiasm with which they present it is actively shaped by their own training era, the specific protocols of their institution, and their personal risk aversion.
There is actually a brilliant study mentioned in our stack that proves exactly this. It's called the Vast Study Variation in Surgical Technique.
I love this study.
It's so revealing. It focused on a native tissue anterior repair for prolapse. And the researchers found that even when surgeons claim to be performing the exact same procedure, their actual physical techniques in the OR vary wildly.
Because the micro decisions in the operating room change the outcome.
Right.
When a surgeon performs fascial dissection, which is separating the connective tissue from the vaginal wall to repair it, some use blunt dissection, some use sharp instruments.
And some excise redundant tissue, while others just plicate or fold it.
Exactly.
And the study proved those subtle, almost invisible variations in technique directly alter the success rates for the patients, which really shatters the illusion that surgical evidence is just this monolith.
It's not a monolith at all.
Right. A native tissue repair performed by Dr. A might have a structurally different outcome than the exact same repair performed by Dr. B, simply because of how they hold the scissors.
This is exactly why relying purely on a clinician's default recommendation can be such a trap. I mean, think about it. A surgeon who has performed 1,000 vaginal hysterectomies with excellent results is naturally going to view the evidence for that procedure more favorably.
Of course they would.
They might subconsciously downplay that 18% risk of posterior wall bulging because they feel confident they can manage it. But if the patient blindly accepts the doctor's confidence without interrogating the evidence themselves, they are at a massive risk for decisional conflict.
Decisional conflict. The sources define that as the state of uncertainty a patient feels when they don't fully grasp the risks, or when they feel subtly coerced into a choice that doesn't perfectly align with their values.
Yes. And the consequence of that conflict is severe.
The data in the sources shows that when decisional conflict is high before a surgery, the patient is 6 times more likely to experience post-decision regret.
6 times. That is huge. That represents a profound level of psychological distress and remorse, which often severely compounds the physical recovery.
It reminds me of buying a house.
Okay, how so?
Well, if you just walk through an open house, look at the real estate agent's glossy brochure, and sign the mortgage based entirely on their enthusiasm, you might be thrilled initially.
Sure, you're excited.
But if the roof starts leaking on day 2, you will feel cheated, angry, and deeply regretful. You'll blame the agent.
But if you hire an independent inspector for a full structural survey...
Exactly. If you use a patient decision aid to aggressively interrogate all the medical evidence, the good, the bad, and the unknown, you might still decide to buy a house with a damaged roof.
Because maybe you love the neighborhood.
Right. And you're willing to accept the cost of the repair. So when the roof leaks, you aren't happy, obviously, but you don't experience that toxic regret. You own the decision because you made it with your eyes wide open. You understood the mechanical blueprint before you bought the engine.
I love that. That alignment between objective data and subjective acceptance is the ultimate goal of shared decision-making.
So, synthesizing everything we've covered today from this incredible stack of sources, comparing evidence between surgical and non-surgical treatments isn't about finding a singular objective cure hidden in a spreadsheet.
Not at all.
The process requires dismantling the anatomical information gap first. You have to understand that a prolapse isn't just a bladder leak. It's a structural failure. Then you have to ruthlessly separate short-term marketing from long-term safety data.
Recognizing that high satisfaction in an experimental laser clinic does not equate to peer-reviewed safety.
Exactly. And finally, you have to embrace a post-Montgomery legal landscape. The doctor no longer dictates what risks matter. You use patient decision aids to map the statistical realities of a colposuspension or a hysterectomy directly onto the life you want to live.
It's about putting the context back into the numbers.
You take the mechanic's complex blueprint, you figure out where the belts are, and you decide what kind of driving you actually want to do. We've explored how empowering this shift to shared decision-making is, putting the agency back in the hands of the patient. But looking at how fast the landscape is evolving, I'll pass it to you for our final thought.
Well, we rely heavily on the idea that if a patient applies their values to the evidence, they can give true informed consent. But medical technology, especially heavily marketed private clinic treatments, is moving faster than rigorous clinical trials can ever hope to keep up with.
Right.
So as you take control of your healthcare journey, consider this. How do you truly give informed consent or weigh a material risk when the long-term safety evidence for the newest, most celebrated treatment hasn't even been written yet? Are you making a deeply informed, preference-sensitive choice, or are you simply volunteering to be the next data point in an ongoing experiment?